Pharmaceuticals. I welcome you all for today's webinar on childhood ALL, fine-tuning the treatment, organized by Mumbai Hematology Group under the guidance of Dr. M.B. Agarwal sir. At MCure, it is our commitment and endeavor to collaborate with clinicians and provide them the platform for scientific discussion on latest update in patient care. We are indeed grateful to Dr. M.B. Agarwal sir for giving us opportunity to be a part of this scientific fest, and I'm honored to invite sir for this event. Sir doesn't need any introduction. He's the president of Mumbai Hematology Group. He's currently professor and head of department hematology, Bombay Hospital, Mumbai. Sir has more than 30 years of experience in hematology. He has more than 80 articles in national and international peer-reviewed journal, and he's the editor of various journals. He's also written chapters in various books. So, sir, without any further delay, I hand over this session to you, sir, for the further direction of scientific proceedings. Thank you very much, sir, for giving us this opportunity. Thank you, sir.
Good evening to one and all. Today, our guest speaker is Dr. David Tiche from Philadelphia, US. He's going to speak to us on childhood acute lymphoblastic leukemia, fine-tuning the treatment. This webinar is brought to you by Mumbai Hematology Group. It is supported by MCure and managed by Perfect Square. I thank Mr. Kayur Soni and the team from MCure, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, of course, the most importantly, our guest speaker, Dr. David Tiche from Philadelphia, all our discussants who are themselves eminent pediatric hematologists or medical oncologists, you participants for sparing your Saturday evening if you are from India, and morning or afternoon if you are from the other part of the world. Do remember to visit the website of Mumbai Hematology Group, www.mhgindia.com. There is no password and all our future academic activities are displayed there. Tomorrow morning, that is Sunday, 13th of November, 11:30 a.m. Indian Standard Time, we have Dr. Anand Deshpande speaking to us on advances in blood transfusion medicine of relevance to a clinical hematologist. Our discussants today are very important personalities and they are displayed here alphabetically, and I'll introduce them to you. Dr. Pankaj Dwivedi from Nagpur, Dr. Aishwarya Raj from Ahmedabad, Dr. Bijita Datta from Kolkata, Dr. Dipti Rani Samanta from Cuttack, Dr. Gunjan Prasad from Kolkata, Dr. Radhika KK from Hyderabad, Dr. Madhvi Madali from Vellore, Dr. Mopali Ghosh from Kolkata, Dr. Nidhi Dikshit from Kolkata, Dr. Nidhi Jain from Ahmedabad, Dr. Parinitha Gutha from Hyderabad, Dr. Priyanka Agarwal from Varanasi, Dr. Rajni Priya Yedla from Vishakhapatnam, Dr. Reshma Roshan from Srinagar, Dr. Revati Raj from Chennai, Dr. Roshni Pandey from Jabalpur, Dr. Seema Bhatodekar from Vadodara, Dr. Shruti Kakkar from Ludhiana, Dr. Sirisha Rani from Hyderabad, Dr. Smita Kayal from Puducherry. And now, to introduce our guest speaker. He doesn't require any introduction. He has been our regular faculty. He has spoken to us and taught us about childhood acute lymphoblastic leukemia at number of occasions during this pandemic. He's Director, Clinical Research Center of Childhood Cancer Research, Associate Professor of Pediatrics, Division of Hematology and Medical Oncology, Children's Hospital for Philadelphia, Perelman School of Medicine, University of Pennsylvania. His areas of expertise include acute lymphoblastic leukemia, ALPS, HLH, and bone marrow transplant. He did his medical school from Eastern Virginia Medical School, Norfolk, Virginia. His pediatric residency was at Children's National Medical Center, Washington. His fellowship in pediatric hematology and oncology was from Children's Hospital of Philadelphia. He was postdoctoral research fellow in pediatric hematology and oncology at the Children's Hospital of Philadelphia. Today, he's going to lecture us on childhood acute lymphoblastic leukemia, fine-tuning the treatment. So over to him. Thank you so much.
Can you see my slides okay?
Yes, sir.
Okay, so thank you very much for the kind introduction and for the invitation to come back and speak today. I'm going to talk today about childhood acute lymphoblastic leukemia, fine-tuning the treatment. Some of the slides I'll show today I've shown in previous meetings, and some of them are updates and new. I have a number of disclosures that are listed here. I won't go through them all. The improvement in cure rate for children of acute lymphoblastic leukemia is one of the great success stories in modern medicine. This was a disease that was completely incurable 70 years ago, and in 2022, the overwhelming majority of children are cured. That said, there still are plenty of patients who are not cured in an upfront setting. There's also, not only has there been improvements overall in acute lymphoblastic leukemia, when we think of acute lymphoblastic leukemia, we typically divide patients into, based on their immunophenotype, into B-cell acute lymphoblastic leukemia and T-cell acute lymphoblastic leukemia. And while T-ALL historically did worse than B-ALL, with modern therapy, their outcomes are actually very similar. So how did we get to be where we are over the past 50 to 60 years as far as improving cure rates in ALL? One thing that happened, and this was mainly from work that happened in Europe and St. Jude, was recognizing that the CNS is a sanctuary site requiring focused therapy to prevent relapse. There's a lot of studies, that I'll go over some of them, that
Mama, I did not do anything.
This is all your fault.
does everybody mind putting themselves on mute?
How come
we
it's not
augmented-
my fault?
You only keep doing something now. The host is muted.
We augmented traditional therapies based on dose scheduling combinations. And then we also developed modern risk stratification, identifying which patients are more likely to do poorly and need more therapy, and which patients are likely to do more better and may need less therapy. And this includes clinical variables such as age and white blood cell counts, but most importantly, response to therapy, and also some genetic subtypes that I'll talk about. And most of this came from agents that were developed between the 1950s and 1980s. And most of the drugs that we use to treat ALL across the globe are ones that are over 40 years old. And it's really been tweaking how we give these drugs in different combinations that has got us to be where we are. The issue, though, in ALL is there's still a lot of places where we could do better. While we're very good at curing and treating patients who are newly diagnosed, we're not as good in the relapse setting. Outcomes for children and young adults of relapsed B-ALL have improved considerably over the past 15, 20 years, a lot of it from the advent of immunotherapy, but it's still, we're not curing the majority of patients. And then there are some groups, including T-cell acute lymphoblastic leukemia and infant leukemia, that we do very poorly. As I mentioned before, outcomes for children with infant leukemia continue to do bad, and we've done a lot of trials in North America. There have been a lot of trials in Europe, and so far, most of our changes have not made many headway as far as curing more kids. Another group that we've had similar thing is poor risk biology, such as hypodiploid ALL, where we continue to do poorly despite augmenting therapy, treating those patients differently. But we're now starting to incorporate novel therapies, both for infants and hypodiploid ALL, and hopefully those will improve the cure rates in these two groups. And I think it's also important to highlight that one of the reasons we still have a long way to go is there are patients that we currently consider standard risk or low risk, or actually the majority of our treatment failures. And B-cell acute lymphoblastic leukemia, and part of this is just a numbers game, about half the patients who relapse or fail treatment are ones that we define as standard risk or favorable risk when they walk in the door. In TLL, this is even more true, where most of the relapses occur in patients who are identified as very favorable risk. So how do we tackle the problem moving forward? As I mentioned, we got to be where we are primarily from identifying patients who do poorly and intensifying therapy, and then reducing therapy for low-risk disease, but we're not really making headway doing that anymore. moving forward, we need to do better at identifying high-risk patients. We need to introduce more targeted therapies and immunotherapies, and potentially change the way we design clinical trials. As I kind of alluded to, we've kind of got to the precipice of where we're going to get with intensifying chemotherapy. In the Children's Oncology Group over the past 15 years, there was a number of studies that were run that I won't go through all these in detail. But the biggest take-home point was most of them looked at intensifying therapy, for example, giving additional blocks like delayed intensification, intensifying consolidation, adding in more. And all of the studies listed here showed no difference in outcome with this intensification of therapy. So we kind of plateaued at what we can do for that. Another thing which is important, I think, to highlight is we are doing better in places that need a lot of work in North America and elsewhere. And that is kind of leveling the playing field for patients who self-report of different race and ethnicity. In the US, for example, patients who self-report as Black or African American used to have markedly inferior survival to white children. However, that is now getting to be comparable as there's been a markedly decrease in death rates for certain groups in North America, although they're still not the same, which I'll talk about. These are some data that were presented by Sumit Gupta last year at ASH that looked at outcomes based on race, self-reported race and ethnicity in the Children's Oncology Group, going back over almost a 20-year period of time with over 10,000 children. On the left is B-cell acute lymphoblastic leukemia. On the right is T-cell acute lymphoblastic leukemia. One thing that we were surprised to note is that patients of T-cell ALL, there's actually no difference in outcome based on self-reported race and ethnicity. In contrast, in patients of B-ALL, we definitely see inferior survival, both for children who report or self-report as Hispanic and those who self-report as Black or African American. This has gotten better over time, but there's still disparities in outcomes, and we need to start addressing them. One of the main things that has kind of really changed the paradigm on how we treat B-ALL in particular, but also now starting in TLL, is understanding the biology of the leukemic blasts. And in 2022, we can really subdivide B-ALL and T-ALL based to genetic groups, some of which are highly prognostic and some of them are targetable. And I think that between genetic discovery, we've really learned a lot more about B-ALL and TLL biology over time. Recently, just this past month, the Children's Oncology Group, in collaboration of St. Jude Children's Research Hospital, combined what they call the Pan-ALL paper. Over the past 20 years, there's been a number of studies that have performed genomic profiling, whole genome sequencing, whole exome sequencing, whole transcriptome sequencing in large cohorts of patients with B and T ALL. And they recently put all those patients together over dozens of publications into one seminal paper, which can actually talk about the overarching genetic landscape of ALL, where patients with B and T ALL can be broken into major groups. In BLL, we tend to lump patients based on chromosome abnormalities, such as hyper or hyperdiploid, of hyperdiploid doing very well and hypodiploid doing worse. Transcription factor rearrangements like ETV6-RUNX1, and then other abnormalities, including kinase-driven ALL, such as pH-like and pH-positive ALL. And I'll talk about that in a little bit of detail. But what this has also now allowed us to have the power to do, because we have enough patients, is not just look at patients at the genetic level based on their sentinel genetic driver, but also drill down a little bit and start saying in those groups, so comparing patients who have pH-like ALL to IAMP21 ALL to ETV6-RUNX1 ALL, what other cooperative genetic lesions are there and do they impact prognosis? And this paper is very nice in the fact that it actually starts breaking that down to talk about the frequencies of certain lesions based on the genetic subtypes, things like what percentage of patients have PAX5 deletions in pH positive versus pH like. And then more apparently can start to see, are there changes in outcome based on subtype? And just a few examples that came out of this. ETV6-RUNX1 and hyperdiploid ALL are very favorable biologic subtypes, but within them, if you have enough patient numbers, you can actually start to tease out, and patients who have TEL-AML1 or ETV6-RUNX1 who have a TBL1 XR1 alteration versus wild type, there is a difference in outcome in that subgroup. Also, in patients of hyperdiploid ALL, a very favorable group, rare numbers of those who have SETD2 alterations have markedly inferior outcome compared to patients who do not have those. Other examples of this include TCF3 PBX1, what used to be ET8 PBX1. Those patients, if they have CDKA and 2A rearrangements, that imparts poor prognosis on that group. And then in TALL, just as one example, patients who are of the TAL1 subtype, and I'll talk a little bit more TALL genetics later in the talk. If they have PFH6 alterations, they have markedly inferior outcome. Of note, there are only 5 patients who met this combination on the study, so you always have to be careful when it comes to very, very rare numbers. But I do think we're entering an era in understanding the genomics of B and TALL, where we can start to really refine who we define as higher and lower risk, not just based on their driving alteration, but more nuanced as far as what cooperative mutations they have. The downside of this, though, is it gets very complicated as it gets more and more costly to continue to test for more and more genes, and whole exome sequencing, whole genome sequencing, and whole transcriptome profiling are still not easy to perform across the globe outside of major centers like St. Jude Children's Research Hospital that sequences everybody with whole genome sequencing. Why does it matter other than identifying patients who are high risk? I think years ago, the paradigm was kind of changed with BCR-ABL1 ALL. This is a type of ALL that had markedly inferior outcome with chemotherapy alone or chemotherapy plus transplant. But a number of studies over time have shown if you incorporate tyrosine kinase inhibitors in there, outcomes are not only better, but outcomes actually do fine and do better even without bone marrow transplant. So adding in a tyrosine kinase inhibitor has completely changed the paradigm of how we treat that. And there are other groups that were making similar inroads, one of which is PH-like ALL. This is a subtype of B-cell acute lymphoblastic leukemia that's enriched in Hispanic populations. Part of the reason that Hispanic populations in North America have worse outcomes. But they had a gene expression profiling that looked like BCR-ABL1, but they were BCR-ABL1 negative. There's been a lot of studies that have dived into this subtype of ALL, which does worse if they're NCI high risk. For example, on the right, showing their overall survival is about 20% less with just traditional chemotherapy. And it is a very complex group of BALL, where they can have sequence mutations or structural alterations and a number of genes that from an expression level look very similar because you have downstream activation of similar signaling pathways, including JAK-STAT and others. 50% of these patients have CRLF2 rearrangements with or without JAK mutations. Another group, large group of them have rearrangements in JAK and EPOR1. And then there's about 10 to 15% actually are not JAK-STAT kind of driven. They're more driven by other alterations in ABL class genes, such as ABL1 and ABL2. They're not BCR-ABL1, but in many ways they're similar. And based on this, there are a number of trials going on around the globe looking at incorporating tyrosine kinase inhibitors such as dasatinib in patients of ABL class mutations and JAK-STAT inhibitors in other patients. There'll be some data on this that will be presented at ASH next month, some of the early results of some of the COG trials, the 1521 trial, incorporating ruxolitinib into the backbone to see if that can improve outcomes. One group that I mentioned very early that does particularly poorly are KMT2 arranged ALL infants with that. They have very dismal outcomes, and we have not made any improvements with intensifying chemo or stem cell transplant for decades, but I think we're finally starting to have some active novel therapies that are effective. There's some nice work, I'll talk about immunotherapy later, adding in blinatumomab in infants with ALL that's been presented at a couple meetings, and I believe will be published soon, that's coming out of Europe, that have showed that incorporating immunotherapy in infant ALL markedly improves outcomes in the de novo setting. But there's also a number of small molecule inhibitors, such as menin inhibitors, that are showing a lot of promise in relapse. There's a current trial that's under development at COG that's going to be studying this menin inhibitors in children with infant ALL. And this is all based on promising preclinical data that looks at the interaction of menin and how it impacts the MLL fusion gene, and how if you block it with a menin inhibitor, such as the syntaxin compound, at least in preclinical models, it leads to differentiation of leukemic blasts that are highly effective, and we'll have to see how well that translates into the clinic. Some early phase trials in adults, though, have looked very promising at KMT2A rearranged ALL. And there's actually some joint initiatives across a lot of the North American cooperative groups to try to design trials that both include children and adults with KMT2A. So changing our trial paradigm, instead of treating patients based on age on certain trials or NCI risk group to try to go with some of our cooperative colleagues and start taking all patients, for example, that have K2A rearranged leukemia, and is the concept, can we start treating them on a uniform backbone that's molecularly driven instead of being driven arbitrarily based on the hospital you're treated at in the US? And I think one of the things that's important to note is targeted therapy and precision medicine is not just picking the right new agent to add onto it. Sometimes it's tailoring your therapy to the biology itself, just of our conventional cytotoxics. And I think the best example of that is some data that came out of Tokyo. In the 1990s, they performed a trial where the goal was to reduce therapy to 1 year for all patients. And they preserved intensity at the expense of maintenance. But when they did this, relapse rates were very high, with an EFS of 56 versus 71%. So it dropped considerably when they used this thing, when they use this, this paradigm of actually cutting maintenance, and especially in some of the favorable patients. Years later, they actually went back with more modern day techniques and took patient samples that were banged from that trial and thawed them and then performed genomics on them. And while the numbers are small, they found that patients with ETV6-RUNX1 and TCF3PVX1 who were treated with just 1 year of therapy had a 10-year disease-free survival of over 90%. On contrast, hyperdiploid ALL, which we usually lump together with those other two groups and treat them very, very favorably, they only had a 10-year disease-free survival around 50%. So same high, very favorable risk patients, small number cure rates to traditional, versus others of those, the same favorable risk group actually did markedly worse if you removed 2 years of therapy. And this kind of just shows that sometimes when we make our tweaks to our backbones and how we treat patients, we have to be cognizant that we lump a lot of patients together, and it is possible some will benefit and some will not. That if you look at the overall study results, you would say this study is a bust. But if you drill down on it, there actually are some things that are important that came out of it. And based on this, they're doing a follow-up study where they're trying similar, but really only doing it in prospectively in patients with certain genetic alterations. T-cell acute lymphoblastic leukemia is another type of ALL that really, this is an area that I study a lot, that we now have a lot of exciting therapies that are finally starting to come to the clinic as we've learned more about TLL biology. TLL biology is more complex than BLL. It's harder to define, to break it down by into groups based on sentinel genetic drivers. A lot of patients with TLL have dysregulation of a number of signaling pathways, and through that, there are a number of different targeted approaches that we're using right now in TLL. One way that we're actually trying to improve understanding of TLL is to really dive down into T-cell acute lymphoblastic leukemia and T-cell acute lymphoblastic lymphoma biology, and I'll talk about why it's important to study both in a few slides. This is a large project that I've been leading in collaboration with a number of investigators across North America: Charles Mulligan at St. Jude, Jun Yang, Kai Tan at Murray Center, a lot of young talented postdocs who are working on some of this work who are listed here, where we recently completed whole genome sequencing, whole transcriptome sequencing, whole exome sequencing of tumor, and whole genome sequencing of germline of over 1,300 kids with TLL uniformly treated on a singular trial. We also then performed single cell sequencing on a large cohort of those patients, and are now also starting to sequence a large cohort of patients of T-cell acute lymphoblastic lymphoma, and then doing functional work and testing novel therapies as we're finding genetic lesions. Because of time, I'm not going to go through a lot of the data, though. I'll show a snapshot of some of the bulk sequencing, but not getting the single cell profiling. But for those of you who are attending ASH this year, we have a number of abstracts that are going to be presented on Monday. There's a whole session dedicated to T-cell ALL omics. There's some nice data coming out from the UK, led by David Connor, and then the bulk sequencing and single cell sequencing work that I'm alluding to here will be presented at that meeting. One of the reasons that we don't understand a lot about TLL biology, and a lot of our omic endeavors in the past have not really elucidated more on as far as what lesions are prognostic, is there's been some issues in the way that people have done comprehensive omic profiling in TLL. One is that there's been a hint based on other papers that a lot of the major drivers in TLL are non-coding. In most studies that are published out there, including the pan-target paper that just came out this past month, only looked at the whole exome level. The other probably bigger problem is most studies that are published excluded most patients of relapse and refractory disease. And the reason for this is most ALL large genomic efforts get their germline sample from their remission marrow. But if you never get in remission, those patients were excluded. So a lot of the published studies that have looked at lots of patients of TLL, the outcomes in those are actually markedly better than the overall cohort because they excluded the higher risk patients. That made it impossible to correlate omics with outcome. For this large cohort that we sequenced, we actually, the first thing we wanted to do is we didn't sequence everybody on the clinical trial because they didn't all have available samples, but we wanted to make sure that the 1,300 we sequenced out of the 1,500 total reflected the overarching cohort, and they did. It was fortunate to work with our colleagues at St. Jude's who have a lot of very complicated pipelines that we could put through the sequencing data because we did do whole genome sequencing of tumor and germline over 1,300 kids. So far, we've been able to identify the oncogenic driver in over 94% of samples, and we are in the process of trying to interrogate that last little bit, which can sometimes be difficult. My guess is at the end, when we're all done, probably over 98% of samples or patients will be able to identify the genomic driver. And in most of these cases, the main primary driver is mutually exclusive. So patients either have a tau1 alteration or they have another type of genetic alteration. The other thing that we noted, which I think is important, and one of the reasons that we've failed in the past to really risk stratify TLL, is over 60% of cases, the putative driver was actually in non-coding parts of the genome. So if you did next-gen sequencing, targeted sequencing, or whole exome sequencing, you would actually miss the driving lesion in the majority of cases. And if you're missing the driver, then you can't really understand the biology to actually understand the prognostic implications. If by integrating transcriptome profiling with the genomic drivers, we were able to subdivide patients of TLL into 16 different groups, many of which have been published before, some of which are novel. I'll walk through them on the next slide. The different groups based on expression profiling are on the left. So for this, each dot represents a different patient with TLL, and the closer the dots are in space is the more closely related they are. The further they are in space on a UMAP, the less likely related they are, and patients clustered into different groups. And some of these groups, which I'll talk about, like TXL3 and TXL1, almost all of the drivers in that group are the same as the UMAC group. In other groups, though, it's far more heterogeneous. And then I think one thing which we're very excited to see is if we start subdividing TLL this way, we can actually now, for the first time, start identifying patients that are at a high risk of treatment failure versus ones that are very likely to do well. As you can see here, there are some groups divided, and this is based on their expression grouping, that have very poor prognosis, and some groups that do very well. Kind of trying to understand what drives a lot of these different groups that we've identified. We integrated the whole genome sequencing with the whole transcriptome profiling to look at each of these major groups. And I'll just talk about a few of them just to show examples. For some of these groups, like as I mentioned before, TLX01 or TXL3, the oncogene expression of these is associated with distinct subtypes. So if you look at those groups, the primary lesions in there are mostly TXL1. So in the TXL1 group, it's TXL1 rearrangements or deletions. The TXL3 group is primarily TLXL rearrangements, mostly BCL11B or other rearrangements, versus in other groups, it's far more complex. So one way that TLL has been subdivided in the past is to break it into groups primarily driven by tau1 and then also T cell maturation markers. So one of these groups is tau1RA, which has low T cell maturation markers. Another one is tau1RB, which has high T cell maturation markers. But if you drill down at the whole genome level, there are various types of activation mechanisms. For example, in tau1RA, there are patients that the primary driver is tau1, but others it's LMO1 and others it's LMO2, versus the tau1RB group, it's the same 3 plus LYL1 and tau2. And this can be from TCR gene rearrangements, fusions, very complicated things like enhancer hijacking and amplifications, which basically means that you have a mutation in the non-coding part of the genome that leads to enhancer that activates a different gene or the same gene, and also SNVs. So there's mutually exclusive oncogene activation, however, overlapping transcriptional networks. So you get the same transcriptional profile, even though you have different oncogenes that activate to lead you there. That just shows some of the complexity in TLL biology that we're still continuing to tease out. And what I didn't show here, but we're also drilling down on, is starting to look at actual genetic mutations and their prognostic value. For example, and this is data we'll show at ASH, patients who have Notch mutations who have excellent outcome regardless of their MRD response, all over 90%. Patients who do not have Notch mutations, though, have markedly different outcomes based on their MRD. Patients without Notch mutations that are MRD negative after a month of therapy do as well as patients with Notch mutations. Patients who don't have a Notch mutation and are MRD positive do very poorly, with EFS around 70%. Part of the way that we've improved outcomes in TLL over the past 20 years is by incorporating novel therapies. There's been 2 recent studies done by the Children's Oncology Group. The first was ALL 0434. In this study, which was run by Kim Dunsmore and Stuart Winter, patients were treated with a 4-drug prednisone-based induction, risk stratified into 3 groups based on early treatment response primarily, and underwent 2 randomizations. It was a 2x2 pseudofactorial design. All patients were randomized to receive Capezi or high-dose methotrexate, except for those who were induction failures, who were non-randomly assigned to high-dose methotrexate. And intermediate and high-risk patients are randomized to receive or not receive nelarabine. On this trial, T-cell lymphoma patients were treated with the same backbone, with the only difference they were risk stratified differently. They did not participate in the Capezi versus high-dose methotrexate randomization, but high-risk patients did participate in the nelarabine randomization. Results of this study have been published in a number of high-impact papers in JCO. The bottom line was that in T-cell acute lymphoblastic leukemia, nelarabine improved disease-free survival, and the Capezi methotrexate improved event-free and overall survival. And the nelarabine's benefit was by a reduction of CNS relapse. In contrast, while there was improvement in disease-free survival in T-cell acute lymphoblastic leukemia, there was no difference in outcome in patients with T-cell lymphoblastic lymphoma. For years, we said this was because the study was underpowered to answer this question, but I actually think that's not the case. I just don't think that it actually showed a difference, and more patients wouldn't have made a difference, and I'll explain why over a couple slides. The successor trial was one that I was a study chair on. This was the ALL 1231 clinical trial. This trial had 2 main objectives. One, we wanted to randomize patients to receive or not receive the proteasome inhibitor bortezomib. They were given 8 total doses, and induction and delayed intensification. The other thing we wanted to do was to try to get rid of radiation in the majority of kids based on the long-term side effects of cranial radiation in young children. On the predecessor trial, over 90% of children received radiation. On 1231, less than 10, it was only 7% of patients got cranial radiation. And the way that we did that was intensifying the backbone based on some data that came out of the UK, where we gave a dexamethasone-based backbone of extra-asparaginase. And made a number of other small tweaks to the backbone. Patients on this study were risk stratified differently on the last study into 3 risk groups. The difference between standard and intermediate risk patients was getting 1 or 2 intermaintenance phases, and a subset of patients who were N consolidation positive were treated with very intensive therapy to see if they could avoid transplant. T-cell lymphoblastic lymphoma patients were also included on this study and underwent the same bortezomib randomization. We also made the same changes to the backbone and intensified it, even though patients with T-cell lymphoma don't historically get cranial radiation. 1, to harmonize therapy for TLL and T-cell lymphoblastic lymphoma, and 2, we erroneously assumed that T-cell lymphoma patients would benefit from the same changes. What we were surprised to see at the end, and these are recently published results that just came out last month, children with T-cell acute lymphoblastic leukemia had no benefit, whether on the randomization to receive or not receive nelarabine. In contrast, children of T-cell lymphoblastic lymphoma had improved both event-free and overall survival. There was a 10% survival advantage with the addition of bortezomib. This study did close early when the results of 0434 were released, because it was felt to be infeasible to add nelarabine in at that point in the trial, but it probably wouldn't have made a difference anyways, because if we only enrolled 847 of expected 1,200 patients, but if we had enrolled 400 more, it wouldn't have changed these outcomes based on disease type. One other thing that we noticed more recently as we were drilling down on the data is patients who were with T-cell lymphoma treated on the control arm did markedly worse than expected. Historically, if anything, T-cell lymphoma patients do as well as T-cell leukemia patients, but patients on the control arm who did not get bortezomib had a 78% overall survival. And most of these events were actually relapses. Versus the bortezomib arm, it was 89%. And if you compare that to the last study, that was comparable to what we saw with or without nelarabine. So we intensified the backbone to improve outcomes in lymphoma patients, and that did not do them any justice. Indeed, if you actually look at it by risk group, the standard risk patients treated with a dexamethasone-based backbone of no bortezomib, so that what we would have called favorable risk patients had a 75% overall survival, which is about 10% worse than expected. We did want to eliminate cranial radiation, which I mentioned in all of our patients, or the majority of our patients, comparing patients on 0434 who got radiation to those on 1231 who did not get radiation. We found the outcomes were similar and there was no differences in the type of relapse. So in TLL, at least by intensifying the backbone, we were able to successfully get rid of radiation without impacting outcomes. And I think one thing that is a take-home message from both of these trials is if you put it all together, over the past 30 years, there's been this harmonization to treat T-cell leukemia and T-cell lymphoblastic lymphoma patients the same. But if you actually look at those two studies, patients with lymphoma but not leukemia had improved survival with bortezomib on 1231. TLL patients but not T-cell lymphoma patients benefited from intensified steroids. TLL patients, but not T-cell lymphoma patients, had improved survival with nelarabine. I didn't show this here, but one thing that is when I showed those race and ethnicity data earlier, self-reported, with no differences in TLL, that's actually not the case in T-cell lymphoblastic lymphoma. Children who self-report as Black with T-cell lymphoma do markedly worse. Children with T-cell leukemia self-report as Black, treated on the same trials at the same centers, do as well as white children. So there's just another big difference between TLL and TLL. And then I'm also not showing it here, but if you look on our relapse studies, the outcomes for relapse T-cell lymphoma are usually around less than 10% versus around 30% for TLL. So while there's been this harmonization of TLL and T-cell lymphoblastic lymphoma, we're realizing there actually are different diseases, and maybe with traditional chemotherapy, they do about the same, but as we start incorporating novel agents, we're starting to see differences come out between the two. And based on that, recently at many centers in North America, including my own, we've started to change our standard of care for the two groups, where the overarching standard of care is similar, using a 4-drug-based induction, followed by a BFM type consolidation, followed by a single intermaintenance phase of capizzi methotrexate, delayed intensification and maintenance. The differences, though, with TLL, we're now using a dexamethasone-based backbone. In the T-cell lymphoma, we're using a prednisone-based backbone. In T-cell leukemia, we're giving nelarabine to all of our patients as standard. In T-cell lymphoma, we're not giving nelarabine to all of our patients as standard. We're giving the proteasome inhibitor bortezomib. So our therapies have started to differentiate a little bit based on the results of these past two trials, which makes it more difficult to plan the next trial. There are a number of novel therapies that are under development and of interest in T-cell acute lymphoblastic leukemia. My group was the first to report that in patients of ETP ALL, there's frequent dysregulation of JAK-STAT signaling, and in preclinical models, they're highly sensitive regardless of underlying genomics to the JAK-STAT inhibitor ruxolitinib. This has led to a number of clinical trials, including one right now where patients with newly diagnosed TLL who have ETP phenotype are getting ruxolitinib, and we'll see how the results of that trial soon. There are some very interesting data that came out of first from Europe and Jean-Pierre Bourquin's lab, followed by Jun Yang's lab, has looked at using tyrosine kinase inhibitors in TLL. In both of these studies, they kind of took a step back and used ex vivo drug profiling to take a large panel of patients with TLL and BALL and treat them with novel agents to see what percentage responded to some drugs. The group by Jean-Pierre's group, they tested over 60 cases, and they found about 30% of cases of TLL responded to dasatinib ex vivo, and most of these did not have ABL class alterations. In fact, only like 1 of the 60 that responded did. They started drilling down deeper, and they found this was that dysregulation of SRC signaling is very common in TALL, and if you use SRC-specific inhibitors, they were very active. They also, in this paper, had a couple cases where they actually treated some patients with dasatinib that actually showed some impressive results. Jun Yang took it to the next step and did a larger cohort of patients with TALL, found similarly that about 40% of TALL is sensitive to dasatinib, and he found that through some nice work integrating their ex vivo drug profiling with transcriptome profiling, they found that ones that are more likely to respond are those with high LCK activity. Recent data that they just got accepted in Nature Medicine, where they presented all their ex vivo drug profiling data, showed that also patients who were sensitive to dasatinib tended to have far worse outcome. So suggesting that there's this higher risk group of TALL that's LCK driven that is likely to respond to dasatinib that needs novel therapies, and we know how to add dasatinib into our current therapy backbone. So one of the reasons I find this particularly attractive is it allows us to take an agent that we know how to easily incorporate into ALL therapy. We just need to figure out the best way to identify these patients at diagnosis, because the preclinical data suggests it's only about 30 to 40% who respond, so we can't treat all of them with dasatinib. Another area of a lot of interest recently in TALL is targeting the apoptotic machinery. There's been some nice preclinical work that have shown that early T-cell precursor ALL is more likely to be BCL2 dependent versus more mature TALL is more likely to be dependent on BCL-XL. That correlates to BCL2 specific inhibitors via venetoclax, showing activity in preclinical models in ETP ALL, but non-ETP ALL, but more broad inhibitors like navitoclax showing activity across the board. Based on this, there's been some recent trials, one of which was just published last year, adding in venetoclax and navitoclax into a chemotherapy backbone into relapsed and refractory patients with B and TALL. This is work that was published by Wendy Stock. Of note on that trial, there were 7 children who had relapsed or refractory TALL, and the overall response rates to venetoclax plus navitoclax plus a little bit of chemo is actually pretty high and better than other studies. And there are studies in development for the Children's Oncology Group, St. Jude, and our European colleagues that are adding in venetoclax and navitoclax into relapsed TALL to try to get more data in a large cohort of kids. This is the trial that's currently in development at the Children's Oncology Group, where we're trying to take advantage of both the venetoclax and navitoclax data I mentioned before and the dasatinib data from June. One of the other things is my lab is correlating with June's, and his lab has shown is that if the patients who are responsive to dasatinib are less likely to be responsive to venetoclax or navitoclax and vice versa. It turns out that more mature TALL is more likely to be responsive to dasatinib, and as I mentioned earlier, it's more immature TALL that's more likely to be BCL2 dependent. So in this trial, patients are going to, with relapsed or refractory BLL or multiple relapsed, or TALL, sorry, or multiple relapsed BLL, will get venetoclax plus navitoclax plus a 3-drug induction. If they have TALL at the end of a month, they'll have a disease evaluation. If they're in a complete remission, they'll continue on a ven-nav-based backbone. If they're not in remission, we're then going to add dasatinib to those patients as well to see if a combination of venetoclax, navitoclax, and dasatinib may be more effective in those patients. So using response to ven-nav to decide who gets dasatinib. Another target of interest recently is in TALL has been targeting the cyclin-dependent kinase machinery. So CDK is often dysregulated, and cyclin-dependent kinases are often dysregulated, including cyclin D3 and TALL. There's been a lot of preclinical work showing that, making some interest in targeting that pathway in TALL. Some nice preclinical data initially done by Ioannis Iofannis, and then some follow-up work in our lab looked at targeting CDK4/6 in preclinical models of TALL, both alone and in combination, showing it was highly effective. I think one thing that we were surprised to see is there was a lot of concern targeting this pathway about how it would interact with our conventional cytotoxics, since we're basically targeting the cell cycle. And there was worry that if we gave it at the same time as vincristine, it would actually decrease the efficacy of our chemotherapeutics. We went to our mouse models and we actually found that was not the case, that if you give CDK4/6 inhibitors at the same time as chemotherapy, you actually get a much better response than if you try to schedule their sequence. And based on this, there was a recent clinical trial run for the Children's Oncology Group by Elizabeth Rates that was presented at ASH last year that added in palbociclib to an intensive chemotherapy backbone that actually showed some responses in some highly refractory kids, just showing it's something of further interest. This was showing the results of some of that trial, which I just kind of highlighted that there were some patients with highly refractory disease who did go into remission with this combination. And based on these results, plus work targeting mTOR, which I haven't gotten into today, there's a study going on at Dana-Farber Cancer Center adding a CDK4/6 inhibitor plus an mTOR inhibitor in relapsed and refractory TLL. For the last few minutes, I'm going to kind of switch gears a little bit and then talk about immunotherapies. So in B-ALL, immunotherapies have really changed the therapeutic landscape, at least in North America and parts of Europe. These are very expensive drugs, so they're not available across the globe yet, but they're starting to become more and more available. There's a number of immunotherapies that have been studied in B-ALL that have showed remarkable promise. Bispecific T-cell engagers such as blinatumomab, which I'll talk about, conjugated monoclonal antibodies such as inotuzumab, and CAR T-cells. Indeed, based on results of trials that have happened over the past 10 years, in 2017 alone in the US, 3 immunotherapies were FDA approved for B-ALL. So earlier I mentioned that most of the drugs that we use in ALL were approved between the late 1950s and the mid-1970s, and then nothing else was really improved for the next 20 years until, actually the next 30 years, until recently, where now we're starting to have, every time you turn around, there's another immunotherapeutic agent that's FDA approved because of some of the efficacy signals that have been seen. The first of those that I mentioned was inotuzumab. This is an anti-CD22 monoclonal antibody conjugated to a conjugated version of it to increase cell toxicity. There was a study first in adults which randomized patients to receive inotuzumab versus standard chemotherapy, which showed better outcomes with the inotuzumab. It's been studied in relapsed B-ALL in children, showing nice salvage rates in some highly refractory patients. Blinatumomab is a bispecific T-cell engager. It basically takes CD3 positive T cells and binds them to CD19 positive blasts. It's been studied in a number of studies. The first, published in the New England Journal of Medicine 2017, similar to the last study, randomized relapsed B-ALL patients to receive blinatumomab versus a chemotherapy backbone, showing initial separation with improved outcomes in blinatumomab, but with time, those curves actually came together. Data in kids in an early phase trial showed it was an active agent. And what were just published in the past year were data from a trial that was run for the Children's Oncology Group, ALL 1331. On this trial, patients with early high-risk disease who are relapsed, first relapse, were randomized to receive chemotherapy versus blinatumomab alone after an intensive chemotherapy reinduction. Patients randomized to blinatumomab had not only improved disease-free survival, they had improved overall survival, and they had less toxicity in the blinatumomab arm. So this has kind of become the standard of care in North America, that patients with early relapse B-ALL, at most centers, they're treated with chemotherapy, followed by blinatumomab therapy, followed by a transplant. There's also been studies in the adult space primarily that have started to integrate immunotherapy with chemotherapy. There's a lot of studies being presented at ASH this year on the adult side where they're basically removing chemotherapy and just giving patients immunotherapy, especially in frail elderly patients. This one study that was published in 2016 that added rituximab onto a chemotherapy backbone in adults, and they gave about 20 doses of rituximab, showed improved survival on the rituximab plus chemotherapy group. CAR T cells are something that have really transformed the therapeutic landscape in acute lymphoblastic leukemia over the past 10 years in multiply relapsed disease. The concept of CAR T cells have been around since the 1980s. And the first trials actually happened in the 1990s, and they were complete busts. And the reason they were a bust is a CAR T cell is basically genetically reprogramming a T cell to attack something else. In the initial studies, they only included the targeted domain in the T cell as they were attacking it. So, and what happened with that, without a co-stimulatory domain, is the CAR T cell would bind to its target, kill the target, but then the T cell would undergo anergy, and you'd kill some cancer cells, but not enough to make a difference. The real breakthrough was actually adding in a co-stimulatory domain. There's two main ones that are used in most CAR T cell products: CD28 or CD28 zeta or 41BB. With both of these, what happens is the T cell binds to its target, it kills its target, but then instead of undergoing anergy, it proliferates and divides and can kill more targets. So you get marked in vivo expansion of the CAR T cell, which leads to cell killing. There's been a lot of trials that have looked at the efficacy of CAR T cells in B-ALL. The Eliana trial was, I think, one of the seminal trials that led to FDA approval. This was an international trial that treated patients of multiply relapsed B-ALL with tisagenlecleucel that led to its FDA approval. In a highly refractory population, the 6-month and 12-month relapse-free survival were over 50%. There's been other CARs, not just tisagenlecleucel, which was developed at Penn, that have been studied around the world. This is just showing a snapshot of some data from Memorial Sloan Kettering CD19/28 zeta CAR that showed with long-term data that it's a highly effective CAR. And in addition to targeting CD19 with CAR T cells, there's now a lot of studies that are targeting other antigens such as CD22, the same antigen in inotuzumab studies. Some data that have been published over the past couple of years show that targeting CD22 is also highly effective in B-ALL. Most of the patients who were treated on some of these CD22 CAR trials have been previously treated with CD19-based CARs. So they're patients who relapsed or occurred after that and still seeing results. And just to highlight how fast the field is moving, the first CAR T cell product was approved in the US in 2017. And 5 years later, there are now 6, and actually another one was recently approved. Most of these are CD19 CARs, but BCMA CARs for myeloma have also been recently approved. So the field is changing rapidly. And based on some of the results that I mentioned before, in relapse setting in the children's oncology group, we've kind of gone all in on immunotherapy and randomized trials primarily to see if they can improve survival in the front line. I won't go through all these, but right now, patients of ALL and with BLL in the children's oncology group are broken down by NCI risk group, and then based on their prognosis, patients with NCI high risk disease, so over 10, white count over 50,000, are randomized. A subset of those, most of them are randomized to receive or not receive inotuzumab. NCI standard risk patients with worse outcomes are randomized to receive or not receive blinatumomab. Very favorable high risk and standard risk patients don't get a randomized intervention. Patients of very high risk TLL or BLL, defined as having persistent disease at the end of consolidation, are getting tisagenlecleucel in the front line. And then we also have a precision medicine arm for patients with ABL class or CLF2 alterations. And hopefully in the next 10 years, we'll see if incorporating immunotherapy into the front line in the randomized trials improves outcomes. And then what I'll finally talk about for the last few minutes is going back to TALL and kind of talking about where we are in the immunotherapy space there, which I think we're finally starting to see inroads and success. So as I mentioned before, in BLL, there's been a lot of success using a number of different immunotherapies, including naked monoclonals, conjugated monoclonals, BiTEs, and CARs. But in T-cell, we really not had the same kind of inroads until very recently. And why is that? There are a number of reasons. One is, what is the best target? And what is the toxicity of targeting that? Unlike B cells, where you can wipe out your normal and your cancerous B cells, if you knock out all of your healthy normal T cells, the toxicity of that's just going to be too high based on the risk of infection. So we'd have to use it as a bridge to transplant. With some products, and depending on the antigen of choice, there's the issue of fratricide, which basically means the CAR T cell or other immunotherapy will attack itself. And then what's become a bigger issue recently, at least getting things approved in the US, is eliminating blasts from the product. So there was a paper that came out with B cell CARs that showed there was a case of a patient where B cell blasts weren't purged from the manufacturing, lentiviral transfected, and basically there was a B cell blast that expressed the CAR, that those B cell blasts were given back to the patient and they expanded and they actually made them resistant to CD19 directed therapies. And since then, the FDA doesn't want any studies that there's a risk that you can accidentally use lentivirus to put the CAR in the cancer cell. Easy in BALL to separate out T cells from leukemia cells. In TLL, it can be difficult in manufacturing to separate the T cell blasts from normal T cells that you're making the CAR. One question that comes up is what's the best thing to target in TLL? Our group and others have looked at this by comprehensive immunophenotype. There are a couple surface antigens, CD5, CD7, CD38, that are almost ubiquitously expressed in TLL. We looked at expression of CD38 over time in TLL and found that it's stable with time and at diagnosis and relapse. Interestingly, if you look at CD38 in BALL, over time, it's actually downregulated just with chemotherapy alone. So targeting CD38 makes sense in T cell disease, but not B cell disease. Based on this, we did some preclinical studies in my lab where we used some of our mouse models of leukemia and treated them with the naked monoclonal antibody daratumumab. And surprisingly, for a naked monoclonal antibody that usually depends on ADCC for killing an immune-compromised mouse without that, it was highly effective in a large number of PDX models. We looked at over 15 different PDXs. These are data that have been replicated by other groups since then, both alone or in combination of other immunotherapies and in combination with chemotherapy. Based on this, we worked with Janssen to develop a trial in first relapse TLL or refractory TLL to add daratumumab into chemotherapy. These data were just presented this year, unpublished so far. But we were happy to see is when we added daratumumab into a chemotherapy backbone that was actually attenuated as far as the chemo we used. Their overall response rate after one cycle was 58%. This was both CR and CRI. It had a way too strict CRI definition. Those patients were actually all in CR. We went back and pulled the data. And then what we were very happy to see is after 2 cycles of therapy, over 80% of patients got into remission, and most of those were MRD negative. Daratumumab and myeloma days take time to see a benefit, and we actually saw this in as well, because most of our studies in relapse TLL, the patients who fail, that don't respond to the first block, do not get salvaged by a second block of therapy. Comparing that to the study that actually led to us moving bortezomib to the front line, the CR1 and CR2 rates were pretty similar. If we looked at event-free and overall survival, they were actually very good for relapse TLL. We need to do better and comparable to other trials in TLL looking at novel therapies. And what we were very happy to see is that a high number of patients were able to get to transplant, which is the goal with a novel therapy like this in relapse or T-cell ALL. Comparing it to the last trial, 07P1, more patients made it to transplant on this trial than the previous one. And based on this, the next trial that we're planning on the Children's Oncology Group with newly diagnosed T-cell leukemia and lymphoma, we are adding in daratumumab in a randomized question. As I mentioned, we've now diverged our backbone and how we treat it. So the trial design initially had the TLL and T-cell lymphoma patients lumped together, but now they're treated separately. We're using the same backbones that I mentioned before, a dexamethasone-based backbone in TLL and a prednisone-based backbone in lymphoma, bortezomib for lymphoma and nelarabine for leukemia. For the TLL patients, we're randomizing those who have positive MRD at day 29 to receive or not receive daratumumab. For the T-cell lymphoma patients, since we're actually not very good at identifying the higher risk patients, we're randomizing all patients to receive or not receive daratumumab. There's also been a number of studies that have looked at using CAR T cells in preclinical models of TALL, targeting CD2, 5, 7, and CD38. I won't go through the data based on time. My lab, in collaboration of Carl June and Richard Applinks and Sarah Gill and Sarah Tajan and others, have developed a CD38 CAR. We expect the trial to open this year. This is just showing some of the mouse data. Following over time, the more the mouse glows, the more disease. This is untreated or untransduced T cells. This was one of the constructs we didn't move forward with that showed some response, but not excellent response. And then the construct we're moving forward with into the clinical trial was curing mice with TALL, not humans, with a CD38 CAR. And finally, there's data coming out now actually using CAR T cells for TALL in the clinic. Almost all of these data that are actually being published are from China, who are now 10 steps ahead of us as far as in the CAR T cell space. because they can get stuff into patients much quicker based on some of the regulatory restrictions that were in North America and Europe. This is just one trial that was published last November that had very exciting results. They treated 20 patients with a CD7-based CAR. Some of those patients, and they basically made the CAR from the transplant donor, and they did it two ways. Some of the patients were patients who previously had a transplant. They went back to the donor to make the CAR T cell. Some of the patients were transplant naive, and they actually collected from the donor the T cells and stem cells for the eventual transplant. And they basically gave patients who were transplant naive CAR T derived from the donor, some of them being haplodonors. And surprisingly, not only did the patients not melt from doing that as far as getting GVHD, 19 of 20 patients on this trial went into remission. The long-term follow-up is actually pretty short, but they're presenting extended follow-up data at ASH this year that are extremely impressive. And what was also surprising was that they found that patients had, and I think one of the most important things of it, had reconstitution of a normal T cell repertoire that was CD7 negative. So it turns out all of us have CD7 negative normal CD4 T cells, CD8 T cells, and other T cell subsets that are just very rare. And under the selective pressure of a CAR T cell, those populations actually grew out. So they actually did have T cell recovery in a lot of patients. When they took those T cells and looked ex vivo, they actually were able to kill virus and fungi. So it may be that why everybody assumed that CAR T cells for TLL could only be used as a bridge to transplant, the data suggests that may not be the case, even though that would be the ideal situation in most patients. And then something that is the last thing I'll show very briefly. One of the other issues in the CAR T cell space, as I mentioned in TLL, is how do you derive a product from a patient who has active disease, who basically has a lot of peripheral blasts? So one of the things in our CD38 CAR trial that'll be tough is how do we make a product for patients we can't get in remission and one of the options for this is to make off-the-shelf CAR T cells, which has been done in BALL. And it's starting to be done in TLL as well. There's a trial in the US right now opened by Wugen. The problem with off-the-shelf products is they typically use CRISPR-Cas9 for gene editing, because they usually require multiple gene edits to prevent things like rejection, GVHD, fratricide, et cetera. And with CRISPR-Cas9, you can get on-target and off-target effects and genotoxic stress. More modern day techniques for gene editing, including cytosine base editing, cause single cell breaks, and in theory would cause less off-target effects, which would allow you to make more edits when you design a CAR T cell. So this is some work that we did in collaboration with Beam Therapeutics, where we basically took T cells and we knocked out TCR alpha beta to prevent graft versus host disease, CD7 to prevent fratricide, CD52 to allow CAM-path to prevent rejection, and PD1 to avoid immune-mediated inhibition. And then we compared CAR T cells with multiple edits that were using cytosine-based editing technology versus traditional CRISPR-Cas9. And I'll quickly run through some of that. If you just looked at T cell proliferation after doing gene editing, with CRISPR-Cas9, the more edits you made, the more it impacted your T cell proliferation to the point where it was down to 50% of expected. In contrast with cytosine base editing, even with 4 edits, it didn't impact T cell proliferation. We did a next-gen sequencing UDITIS assay, which basically is looking for genome rearrangement products, and found with CRISPR-Cas9 base editing, up to 2% of cells actually had off-target genomic rearrangements. In fact, 1/5 had actually gross karyotype abnormalities you could just see under routine karyotype, including things like chromothripsis. If we looked at the downstream implications of targeting multiple things in T cells, comparing cytosine-based editing with CRISPR-Cas9, we found a cytosine-based editing. If you did RNA-seq, we only saw upregulation or downregulation of the genes of interest. With CRISPR-Cas9, there was a lot of off-target effects. With 3 hit edits, we found that in one experiment, we found that over 60 proteins were inappropriately expressed, including things like P53 and apoptotic things. We did some functional testing, which I won't go through, to actually look at the polyfunctionality of CAR T cells derived by cytosine-based editing, showed that they were highly polyfunctional and better than CRISPR-Cas9, suggesting they'd be a more effective product. And then most importantly, when we tested the multiply base edited cytosine-based CAR T cells, in preclinical models, the left looking at a cell line based model and the right looking at PDX models, we found that they were highly effective. So we expect that trials looking at off-the-shelf CART7 and autologous derived CART38 will open in a year at our center. And the last thing I'll kind of just mention when it comes to CAR T cells is we're now finally starting to make some baby steps in to try to get them globalized and seen around the world. Because as of now, most of the trials are in North America or in the Northern Hemisphere. Actually, China has overtaken the US as being the place that is testing more CAR T cells than anybody else on the planet. This is about a year old now, but there were over 300 active trials there. But in part of the Southern Hemispheres, Latin America, Africa, and some other countries, including India, CAR T cells are not as ubiquitous as they are there. But I know there are some efforts that are ongoing to bring CAR T cells and to have more CAR T cell products in other countries. I was just in Egypt last week, and we were talking about how do we bring CAR T cells to Egypt. And I know there's some work looking at doing this in India right now using machines like Prodigy. So it seems like we're entering a time where hopefully the whole globe will have access to this exciting therapy. With that, I'd like to thank the people in my lab who did a lot of the preclinical work I showed today. A lot of collaborators that I have locally at CHOP and UPenn, shown here. I won't go through them all just based on time. That red box was for a different talk. I forgot to take it out here. A lot of leukemia collaborators in the North America and abroad, some of the sequencing work of the Mulligan group, more collaborators. It's been very fortunate that I have lots of collaborators around the globe who've helped with a lot of this work and a lot of the studies for the Children's Oncology Group. And with that, thank you. And I know I went a little bit over, sorry.
That was fantastic. Great update. Many of these things we could not have thought of also. We have some of our colleagues who would like to discuss some questions with you. Before we go to the faculty present here, I'll take one or two questions from the audience. These are questions related to Ph positive acute lymphoblastic leukemia. They want to know how do you select a particular TKI, and then what's the duration of the TKI therapy after the transplant? And also one part of the question is, so who are the patients of a Ph positive ALL who should still be transplanted?
With Ph positive, it's a great question. I don't think there's any complete consensus on this. China recently did a study where they randomized patients with children and young adults with Ph positive ALL to receive imatinib or dasatinib, and found that in that study, dasatinib did better for reduction in CNS relapses. But if people have seen that study, there were some problems in it because the dose of imatinib they used was lower than the dose we traditionally use. So in North America and Europe, for a lot of different reasons, we're still using imatinib as our TKI of choice for BCR-ABL positive on our trials, although I know there are centers that have moved to using dasatinib. So I think as far as TKI choice, the literature not clear over which one is better than the other. There are, again, some randomized data suggesting that dasatinib is better. It's harder to get dasatinib in a lot of places. So our standard in the US primarily is still with imatinib. However, patients who have CNS disease when they walk in the door, we tend to give them dasatinib because it has better CNS penetration, with no great data saying that's the best approach to do. Post-transplant, we do give TKIs to patients with BCR-ABL1 disease. As far as how long to continue it, I think there's studies that are still looking at this, and I don't think there's a complete consensus. A lot of places you continue for about a year, but I don't want to say that's the best amount of time or the least amount of time. In which patients of BCR-ABL1 should get a transplant? It's a great question. I think also something that's not settled yet. I'd say most groups do it based on disease response, and then depending on who you ask, and I think you should just follow a protocol and what was done. That's either end induction response that's poor or end consolidation response. And part of that depends on when you actually started the TKI, because you made the diagnosis. You probably need to be on a TKI for at least a month or so before you make a decision if they had an adequate response where you should take them to transplant. So big picture, poor response to chemotherapy plus TKI equals needs a transplant. How you define that really depends on the TKI you're using and the backbone you're using and when you actually started the TKI. So it's not a one size fits all.
detect the MRD in these patients? Will you do flow, or will you look at the BCR?
So it's a great question too. At my center, we do both flow and we do BCR able by PCR. Most patients, they tend to trend together, but there are some outliers in there. And then typically we take whatever one is worse. But usually the BCR able PCR is the kind of, I would say, the gold standard. I think this is also a thing where it gets tough because it comes down to what do you have access to? Do you have the ability to do both? I think if you had to choose, I would probably say BCR able 1 is the way to go, but flow is a good enough surrogate. And I think that like different countries do different things, so it's a little bit tough.
Good evening, sir. Thank you for that amazing talk on novel agents and the mutational landscape of ALL. I have a couple of questions. One is that pH like ALL, when should we identify them? Upfront or at the end of induction?
It's a good question. I don't think that we usually, so the earlier you can identify them for the rare patients with able class fusions, the better, because then you can add in dasatinib or imatinib, but that's the minority actually of patients with pH like ALL. That's so of the rare subset that's pH like, 10 to 15% have able class. I think right now with the other patients, it's still experimental in the front line if a JAK-STAT inhibitor or other targeted therapy is actually a benefit. So I don't think unless there's a clinical trial that's open in the newly diagnosed setting, I don't think that actually identifying pH like ALL adds that much, other than we know they do worse. So you might start planning for what are you going to do to salvage that patient. In the relapse setting, it's also very important to know, because we knew somebody had pH like ALL and then they relapse, you would be more likely to probably just jump into something with a JAK-STAT inhibitor if they hadn't seen one before. And just know that if you diagnose pH like, you're more likely to be a poor responder. So transplant may be on the table, but it's still not most patients. So the main reason we do it early is, again, for some of the clinical trials, but we still don't know if that actually makes a difference.
And will these JAK2 inhibitors or dasatinib obviate the need for transplant?
It's a great question. I think that's one of the things that we'll have to learn in both of these. Right now, our recommendation is for patients in those trials that if they get those drugs added in, our recommendation for transplant is the same as if they didn't have those. So it's based on response. So patients who have poor response and if consolidation still have a bunch of disease, we'd recommend those patients go to transplant. The hope would be that the incorporation of novel therapies like JAK-STAT inhibitors and TKIs will make more patients MRD negative at an earlier period of time. So then we won't take them to transplant. We could find out that's a mistake. We may find out that while some of these new agents improve MRD response, they don't actually change your overall outcome and therefore shouldn't change the plans to transplant or not transplant them. But I think that's why we're doing studies to learn that, because we don't know.
And if a child has had a STOMI cause during induction, a late relapse of B-ALL, should we give something like 6-MP or should we look for Blina? I mean, what should we do?
So somebody who had a lot of toxicity.
Yeah, a STOMI cause during induction, going on a ventilator, coming out MRD negative. And you need to, you need some time, you need a chemo-free regimen. So what should we do?
So in BLL, we are more and more giving immunotherapy as that bridge, as something if you're sick and you can't tolerate full intensity chemotherapy. In fact, that's what we've kind of done at my center. That's what we're now doing as our standard. So somebody who early into therapy has a bad infection, we flip into like a fungal infection. We're just putting those patients up on blinatumomab until we can get the infection under control. Somebody who got critically ill, kind of, one reason or another, when they come out, if we feel like they need something, we'll start them on blinatumomab. Where in the old days, we used to always just put them on maintenance for a little while. In TALL, I don't have that option yet. So we still have to put them on maintenance therapy. I don't think there's a right or wrong there. I just think there's a lot of data that are coming out showing that blinatumomab in particular is very well tolerated and can be a nice bridge for patients who are really sick and they're not relapsing while you're doing that. Versus always the risk is if you put somebody on.
How many doses?
Of blinatumomab? It really depends on the patient and the infection. We've done it for 3-4 months in patients. We've been done longer than that. In a few patients with bad infections, we've done it for like 9 months or so. But as far as I think the total duration of therapy is less dependent on what we think is the amount of blinatumomab, which is the best. It's more what is the comorbid problem that's not allowing us to use chemotherapy. And then eventually we start to get nervous about just using blinatumomab. So after a few months, I don't know if like a patient who at the end of induction had a bad infection, we switched to blinatumomab. It makes me nervous to say we're just going to put them on blinatumomab for 6 months versus a couple months versus somebody who was almost in maintenance when if they had a fungal infection or something with BALL. I might say that 6 months of blinatumomab makes me much less nervous because it's just maintenance therapy they're not getting. So it really is one of those case by case dependent things as far as length and time.
Thank you, sir.
One more question from the audience. This is related to the various agents you talked about in T, acute lymphoblastic leukemia and lymphoma. Is any one of these agents become a standard of care to be used upfront, like venetoclax or others?
Not yet. Great question. I think that the only 2 drugs that in North America we're considering standard in the upfront setting are bortezomib and nelarabine. And bortezomib for lymphoma and nelarabine for leukemia. The other ones we're still studying, and the hope would be to move them to the front line. So daratumumab we showed was effective in relapse, so we're moving it to the front line in a randomized setting. If that study shows a benefit, then yes, daratumumab would become part of our backbone, but we could find out that it doesn't improve outcome at all in the frontline setting. Venetoclax, navitoclax, and dasatinib are also very exciting agents. The only setting that I would say that some of those drugs are helpful in the front line as far as not necessarily a standard, but considered for patients who have refractory disease. So like we've had patients of TLL who you give them a month of therapy and they're not in remission. We then start consolidation and they have a poor response to that. Then we'll often use daratumumab or venetoclax, navitoclax as a way to try to salvage them to get them to transplant. But that's a rare set of patients.
Hello, sir. Excellent talk, Dr. TJ. I have a couple of clinical queries. Is capizi's methotrexate replacing high-dose methotrexate in all subsets of ALL?
Also, so that a what? BLL or TLL?
Both.
So BLL, the studies were the opposite. They actually showed that high-dose methotrexate was better than capizi methotrexate and like the LL02. So our BLL patients, a lot of them still get high-dose methotrexate. And TALL, on the flip side, we have moved away from high-dose methotrexate based on the results of 0434 and primarily use capizi methotrexate. I'd say that the 2 places that's a little bit controversial and there's differences in sites are, one, CNS3 patients. If you look at the 0434 data for CNS3 for patients who got high-dose methotrexate and nelarabine and radiation, they had pretty good outcomes, like 90% EFS, which is better than anything else out there. My personal bias is the high-dose methotrexate. That was an assumption it would do better, and it doesn't. So at my center, for somebody who's CNS3, we give them capizi methotrexate, nelarabine, and radiation. On the next study, the plan is to treat CNS3 all patients in COG with no high-dose methotrexate or TLL and a capizi methotrexate, and we'll find out if that's effective in CNS3. I think the other thing which is important to note is, we did a trial in the COG, randomized patients to capizi or high-dose methotrexate on a radiation backbone, and capizi clearly won, over 10% difference in improvement. The Europeans, the MRC on the UKLL 2011 trial, they randomized T-cell patients on a very similar backbone without radiation to capizi or high-dose methotrexate. Those results will probably come out in the next year or 2, and if they show a different answer, then that may change things a little bit. We've already talked about that if we find out from that study that with radiation, capizi was better, and without radiation, high-dose methotrexate is better. With the mixed results across 2 different studies that were not identical, we may modify our next study to include both to just hedge our bets, because TLL is definitely a place you try to give your best therapy up front. and try to avoid relapse. So if it turns out that it looks like there may be benefit to both, we would do both. But right now, there's no data that says high-dose methotrexate has much of a place in newly diagnosed TLL.
Thank you for clarifying. Another is what is the role of rituximab in childhood ALL in any setting in the upfront or MRD positive or data?
So I think it has its utility in children, at least, and I'll speak. Part of it depends on access to other drugs. So for us, patients of relapse disease, we often use immunotherapies to try to get you to transplant if that's the goal. And we debate, should we use inotuzumab in this patient or blinatumomab in this patient? Should we give them CAR T cells? And there are a lot of factors that go into those decisions. So when do we think the transplant might make us more or less hesitant to use inotuzumab based on the VOD risk. And then rituximab we use for patients who, for some reason, they can't get any of those or relapse after a lot of those. And we use it in case-by-case rare situations. That said, that we have more easy access to some of those drugs than other places do. And rituximab has been shown in randomized trials to be a very good drug in B-ALL. So I think it's a reasonable thing to use. It's actually, I think this target is fine, CD20. If you are CD20 positive, I think the only downside of rituximab is it's a naked monoclonal. So it's just not as good as a BiTE or a conjugated monoclonal. So we saw that in the CD22, like Elizabeth Raich ran a trial for the COG where they used a naked CD22 monoclonal antibody, epratuzumab. And the results, even with chemotherapy, were not as good as we see with monotherapy of inotuzumab, a conjugated monoclonal antibody. So I think if there was some nice CD20 conjugated monoclonal antibodies or CD20 BiTEs, I would find them much more exciting.
So given that we don't have access to the newer monoclonal antibodies or the CAR T immediately, so we can consider rituximab in the relapse setting.
It's a very good drug. It is effective. Yes. So yes.
Just one last question, if sir permits, is what is the indication of transplant in CR1 in B and TALL for children?
TLL easy, in consolidation MRD positive. TLLs should go to transplant. And I think our last study, I didn't show it, kind of showed that. So on our last trial with TALL, for those who still had disease at the end of consolidation, we gave 3 very intensification blocks that were developed by the BFM. They had high-dose methotrexate, they had high-dose Ara-C, they had etoposide, they had ifosfamide. They were very intensive blocks. At the end of those 3 blocks, patients who are MRD undetectable, we recommended staying on chemotherapy. Patients who are MRD positive of any level still after those, we recommended going to transplant. The MRD negative patients, so basically end consolidation MRD positive, got more chemo, became MRD undetectable, and just got chemo, they all relapsed and died, all but 1. It was small numbers. It was only like 12 kids, but 11 of the 12, the overall survival was less than 20%. For the patients who are in consolidation MRD positive that got intensive chemo and were still MRD positive and went to transplant, they're almost all still alive. Their survival was over 80%. So the patients who had persistent MRD that went to a transplant, almost all alive. The patients who had persistent MRD that we treated with chemo alone and very intensive chemo, almost all died. So I think it answered the question in TLL. If you have disease at the end of 3 months of therapy, you need a transplant. And GBL is actually effective in TLL. So that's easy. BLL's a little bit more complicated. Primarily for CR1, we're using it less than we used to. NCI high risk and consolidation MRD positive, easy, they should get a transplant. Induction failures with bad biology should get a transplant often. It's very controversial. We should be taking our hypodiploids and other bad biologies to transplant just because there's no data that actually it shows the outcomes. So I think it's easy to say that NCI high risk persistent disease, transplant. Some of our other subsets, I think there's not a very good consensus on who should and who should not go. I would basically say for that, follow a lot of protocols, have recommendations on who to and who they did in the last trial. So we usually just follow kind of those algorithms based on the treatment backbone, because I think the backbone does impact those decisions, plus who the donor is. And then sometimes it gets to be a nuanced discussion because like hypodiploid ALL, a lot of places, hypodiploid that's MRD negative or MRD positive, a lot of people would say needs a transplant. because their outcome's 30%, but the outcome of transplant is still 30%. So that gets to be a debate. We typically transplant groups that have an EFS of less than 50% in the US. But for some of those, transplant doesn't actually change that. So is it really the right decision to put them through a transplant? On the flip side, there probably are patients, we just have to look at it, right? There probably are patients with a survival of 70% that actually could get it to 90% for transplant. But we kind of arbitrarily use a 50% cutoff as if your expected outcome is that, transplant them.
Thank you. Thank you.
Hello.
The audience is, the patient remains MRD positive. Which patient should go for transplant or CAR T?
So if it remains MRD positive, in what setting?
ALL after induction and consolidation.
Okay. And it's a good question. So we have a clinical trial right now looking at CAR T cells at the end of consolidation and CR1. And we'll find out if that makes a difference. It's hard to, it can be hard to get CAR T cells for a newly diagnosed patient with persistent disease, even if you wanted to give them to them, because it's technically not per the label. Some insurance companies are willing to, and it's expensive. Some insurance companies are willing to say, you can define that as refractory disease and they'll let you have it. So I would say more often than not at my center and a lot of centers, for somebody who still has persistent disease at the end of consolidation, the standard would probably be blinatumomab to a transplant, or inotuzumab to a transplant, or combination chemotherapy plus an immunotherapy to a transplant. And using a CAR T cell in that setting is experimental. That doesn't mean, though, that if we had a patient at the end of consolidation who had 50% blasts, we're going to push really hard to give them CAR, versus a patient who had 0.2% blasts, where we just need to give them a little bit of something to get them a transplant. We're probably going to do blend to a CAR too. So it's also one of these, probably one size doesn't fit all, because there's a lot of things. Can they manufacture a CAR T cell out of them? Not all patients are successful manufacturing them. Do they have comorbid problems? Is the goal transplant? Who's their transplant donor? What's the timing of transplant? And how much disease do they have? All factor in.
Hello.
Dr. Bapali Ghosh, go ahead with your question.
Thank you so much for the wonderful lecture. I have a question regarding a patient that we have in our setup. The patient is a TALL 11-year-old who received DFM induction, and he was CNS3. Then for post high-dose methotrexate after 2 doses, he developed a CNS toxicity, for which, according to the consultation with our neuromedicine also, we had to give him only Araci-based IT without giving the methotrexate. But we continued with another 2 doses of high-dose methotrexate IV. Now the patient after consolidation has come up with a CNS relapse. So may I know what is your take about this case? Like, where we could have done anything else to prevent this relapse?
So he relapsed after consolidation, you said?
Yes, sir. We have given the consolidation.
Yeah, I don't think there's probably anything you could have done to prevent that relapse. I mean, I think most people, if you had presumed methotrexate neurotoxicity, would hold IT methotrexate for a little while and eventually reintroduce it. Relapsing right after consolidation is very rare, but it does happen sometimes. So I actually don't think there's anything I wouldn't have done anything different in that setting. I would have just typically continued with the same therapy and just held IT methotrexate and then restarted it back up in probably IM1. Sometimes badness happens. I mean, what are you going to reinduce with, or do you know yet? Or what did you reinduce with?
Sir, right now we have introduced again with the TIT with methotrexate, because the neuromedicine has also given a clearance regarding this. But sir, we also want to know regarding what is the role of radiation. We could have gone for a radiation post giving the consolidation to this patient. Was there any role of radiation in between?
So like during consolidation or after relapse?
Post consolidation, after we completed with the high dose methotrexate therapy to this patient.
Before
consolidation.
So I don't believe in giving radiation unless you relapse with TLL or you have CNS3 diagnosis, if that's your question. After
Yes.
relapse of TLL, the CNS relapse is going to need radiation as part of their therapy consolidated to transplant. And depending on how easy they respond to chemotherapy, we would either do the radiation while we're getting their disease under control, or ideally we would give it as part of their TBI and a boost. So we would actually save the radiation and do it as part of the transplant prep instead of, and add another 7 gray to their TBI as a boost.
Okay, thank you so much.
But if you have a hard time getting the patient in remission because they're not responding to chemo, then you could use radiation as a way of inducing remission to get you to transplant. But
Yes, sir. We are planning for that. Thank you, sir.
no.
Can I go ahead and ask Dr. Akarwal?
Yes, please.
So excellent talk, Dr. David. I have a question on bortezomib. We have infant with lymphoblastic lymphoma, T lymphoblastic lymphoma, as well as a bigger child with the around 7-8 years child with the bone marrow involvement of 14%. So in these high-risk cases, do you suggest to give upfront bortezomib instead of waiting for the relapse to happen? Because we know that if T lymphoblastic lymphoma relapses, it behaves very badly. So should these kind of cases, should we go ahead and give bortezomib upfront?
So we are. So newly diagnosed T-cell lymphoblastic lymphoma at my center, they all get bortezomib starting day one.
Okay.
Not everybody in the U.S. is doing that, though. So I shouldn't say that is that is not consensus across the board. I would say many centers do. The next trial, we plan on giving it to everybody, and at my center, we give it to everybody with lymphoma because it did improve cure rate by 10%. Some people say that the control arm did so poorly on 1231 in the lymphomas that it makes it harder to interpret, and therefore they're not giving bortezomib. But the reason bortezomib improved outcomes was all elimination of relapses. All the event differences between the bortezomib and non-bortezomib arm were either progressive disease or relapse. So it seems it's an effective therapy. And as you mentioned, relapse lymphoma is almost impossible to salvage. So we should give our best stuff up front.
Absolutely, yeah. So another question on PH like ALL, like we have no access in India for NGS, and we started doing for everyone almost looking at PH like. But I'm just wondering, like, what is the difference between outcomes in PH like versus PH? So is there any difference if we miss out on doing PH like and identifying PH like upfront? So what is the impact on outcomes?
So PH like NCI high risk. So patients who have a white count over 50 or age over 10 that have PH like ALL do worse. So probably 20% worse than patients who don't have PH like. Versus NCI standard risk with PH like, the outcomes are very similar to patients who don't have PH like. So it seems to be very prognostic in your older kids or your high white count kids. So the problem though is, even though we know it does worse, we still don't know what to do about it on the newly diagnosed setting, except for we are at my center and a lot of centers, if you do have an ABL class alteration, we are considering adding in a TKI as standard of care now, because we have the data in BCR-ABL1 that we know how to safely and effectively do that. And we think they'd probably have the same benefit. On the flip side, outside of that 10 to 15% of PH like, the rest of them, we don't believe there's enough data yet to support just a routine use of other therapies. So we use treatment response to make any decisions.
Okay. So can I ask one more question, just a practical question on aspergillus? Like if you get major complications like cortical venous thrombosis or severe pancreatitis, what is your clinical approach? Like, do you go ahead and give the drug again in reinduction under the cover of low molecular weight heparin, or do you completely omit?
It depends. So for severe, it depends on the severity of pancreatitis. Like severe pancreatitis that has hemorrhage or a pseudocyst, we don't ever rechallenge. For a sinus venous thrombosis, a bad clot, we often don't rechallenge. If it's a small clot, then sometimes, and it's early in therapy, we'd sometimes rechallenge in the setting of anticoagulation. Other clots we rechallenge. So if we had a leg clot we probably would. So we usually say life-threatening thromboses, we don't re-challenge. Non-life-threatening thromboses, we do re-challenge. And then the question is, what is a life-threatening thrombosis? And I think that's where it depends on the patient. Because there are data that suggest if you don't get, if you don't get all your asparaginase, you do worse. But depending on the backbone you're treating the patient with, how much worse varies. So if you're getting Dana-Farber type therapy or St. Jude type therapy, for example, where they give patients 20 to 30 weeks of asparaginase, missing asparaginase is huge impact in outcome because that's so much of their backbone therapy, versus like BFM therapy or COG therapy. Asparaginase is an important component, but it's not that much asparaginase, it's less, so it probably doesn't make as much of an impact in outcomes. So we don't push the envelope as much. I know that like our colleagues at Harvard, where asparaginase is so much of their backbone, they are more likely to re-challenge in lots of different places to try to get more in there. But pancreatitis, if it's severe, is easy. We used to not actually re-challenge any pancreatitis. Nowadays, for somebody who has like a grade 3 pancreatitis that resolves quickly, we re-challenge them.
Thank you.
May I ask one question, Dr. Agrawal?
Come to you. One question from the audience. When you use bortezomib for lymphoma patients, do you drop vincristine?
No, we don't. So on the study, we added bortezomib on top of the vincristine. And when we compare the rates of peripheral neuropathy on the patients who got bortezomib versus who didn't get bortezomib, they were the same. So even though it did not increase the rate of neuropathy, at least in the frontline setting. So we continue to give vincristine per its standard dosing and schedule in ALL and lymphoma when we use it. It's probably because the vincristine is given weekly at first and then goes to every other week and then it goes to monthly, versus bortezomib is really more intensively stacked into 2 4-dose blocks. So you don't get a lot of exposure to bortezomib. You get 4 doses in induction and 4 doses in delayed intensification. So there's actually not that much overlap with vincristine anyways. And if somebody got neuropathy, either bortezomib or vincristine or nelarabine, usually you hold the drug and reduce the dose for a while.
Hello?
Go ahead with your question, please.
Actually, I have a very nice presentation, Dr. David. Actually, I want to know very practical questions. What is the ideal time to do MRD? And in high risk ALL, childhood ALL, how many times you have to do MRD for the better therapeutic outcome?
So if it's the question about, so we only get MRD until you're MRD undetectable or negative, and then we stop checking. So we don't do, because the problem is there have been debates over should we, in the old, like if you go back to the older days in the 1970s and 1980s, when patients were diagnosed with leukemia, they got marrowed in maintenance like every 3 months. There were even studies in the 80s looking at them that they did, like for voice of testicular disease, they did repeat testicular biopsies to look for recurrence of disease or remission. And the field moved away from that frequent monitoring once you go in remission, based on the fact it didn't change outcomes. There are people who debate now that we live in an era of immunotherapy, would identifying a relapse early impact our ability to salvage them? The answer may be yes, but when do you check? And I think that to get a marrow every 2 months or every 3 months or every month is just how often and when. So based on that, we still use kind of the mantra from those older studies in the 70s and 80s that got rid of frequent morphologic monitoring, that we only get a marrow once you're MRD negative if you have things that worry us for relapse, but we just don't do it as far as routine monitoring.
Thank you. Another question of mine is the case of TALL. Actually, he relapsed to BFM 90 protocol after consolidation. In which way we have to proceed? I heard about your venetoclax, like in BCL2 inhibitor. Actually, what is your opinion? In which subset of patients you administer venetoclax?
With TALL? Sorry, I missed with TALL?
Yeah.
So it also gets a little bit complicated that if you have if you only have access to venetoclax and TLL, I would only do that in early T-cell precursor because the preclinical data are pretty strong. There's data from St. Jude in a small clinical trial that TLL except for ETP is unlikely to respond to venetoclax. But it's highly likely to respond to venetoclax plus navitoclax. Navitoclax is just a hard drug to get. It's in the US, it's not FDA approved. There's no clinical trials that offer it right now, but sometimes the company who makes it, AbbVie, is willing to give it under a compassionate use emergency release, and then we would do it. So if you have access to navitoclax, then relapsed T-cell disease, I think we use it often. If you don't have access to it, then I'd only use venetoclax for ETP ALL.
At last, I want to know who are the candidates for CAR T therapy during treatment of childhood ALL?
So, I mean, it's a great question. And it's one that every couple months it changes. So multiply relapsed ALL, BALL, easy, CAR T. First relapsed BALL, it's a little bit more nuanced. We tend to do chemo blinatumomab transplant right now in my center, but a year ago we were doing CAR T in that setting, and then we flipped back, and then we flipped back to 3 or 4 times over the past 2 years in that setting. Refractory disease in the frontline setting, that if you had somebody who's consolidation rate positive, we usually would do blinatumomab next, but if they fail that, we'd probably do CAR T cells. So easy thing is second or greater relapse, CAR T. First relapse, high risk relapse, we'll sometimes do it. So infants, we were taking a lot of them to CAR T cells because they don't do well with chemo or transplant, but now there's the data from Europe showing how well they did with chemo plus blinatumomab and a transplant, that we're now starting to do that and move back away from the CAR T cells. So I think it's just a hard thing, because every time you develop a local standard on what you're going to do, more data is coming out, and then you end up changing it. So I don't think there's a clear answer on which patients should you choose CAR versus blended transplant as example.
Thank you, sir. Thank you so much.
Can I ask one question? Sir.
Dr. Reshma, then Dr. Pankaj, and then Dr. Rajini.
Thank you so much, sir. Thank you for the comprehensive talk. My question is about ATP ALL. What is your current standard? Is it chemotherapy alone, if MRD negative, or you take upfront ETP ALL for upfront transplant?
The data suggests that the kinetics of response are different for ETP, but the overall response is the same. So I don't recommend transplant for ETP ALL unless they still have persistent disease at the end of consolidation.
Reshma, any other question?
Yes, sir. So do we, should we use venetoclax upfront, since it's a high risk, it's a bad disease, ETP ALL, or, only leave it to the relapse? We know the outcome of the relapse is not that great, even with the transplant then.
So I usually reserve it in TLL for relapse. Like, I don't think there's data to suggest that ETP ALL should get venetoclax in the frontline setting. Maybe someday, but we're not there yet.
Thank you, sir. Thanks so much.
And then I think one of the questions on the venetoclax that I see in the chat was, what's the role of it in BALL? I think venetoclax has a place in BALL, but it's usually for patients who failed immunotherapy as another alternative to try to salvage them.
So can I ask one question? So there is what is your experience of in children aged more than 1 year with MLL rearrangement, MLL AF4 versus AF9 or other translocation in more than age 1 year? And another thing is, there is any role of decreasing the intensity step down chemotherapy in case of infant leukemia whose date response is good, MRD negative? Is there any role of decreasing or downgoing for the chemotherapy?
So for the first one, for MLL, I think the easiest answer for that is just this month in Journal of Clinical Oncology, a paper came out from the Ponte Delano group, which combined outcome data for patients with MLL across Europe, North America, across a lot of cooperative groups, and actually has nice detailed breakdown on prognosis based on your age and the type of MLL rearrangement. So if you're like AF4 versus not AF4 and a 12-year-old, it actually has nice tables in there. It actually says what your outcome is. The bottom line is that most patients of KMT2 rearranged B-ALL do worse, but how much worse really depends on the fusion and your age. So, and I don't remember all the nuances from that paper. I still need to digest it more, but I think the best answer to your question is that new paper that just came out, because it really breaks that down in very good detail. And what was your other, no, I forget, what was your other question? I'm sorry. Did you ask the, oh, it was infants and reducing therapy if they had a good response? Yes. I mean, I think one of the biggest questions we're asking right now in the world of ALL is, are there populations we can give less therapy to? And infants are not one right now that I think that we're at a place of giving less. I think the outcomes are so poor that for the most part, we usually tend to follow published protocols and just stick to them, no matter regardless of the response, because overall they don't do great.
Thank you, sir. Thank you for the opportunity. Thank you, teacher, sir. That was an excellent talk. So my question is like for T lymphoblastic lymphoma. So as you have clearly illustrated in your talk, like bortezomib had improved survivals. So what is the role of high-dose methotrexate? What dose of high-dose methotrexate we give? Like it's a 2 gram per meter square or the 5 gram per meter square, which we need to follow. And if in case we go with the 5 gram per meter square of high-dose methotrexate, can we avoid prophylactic RT for these patients? Because these survivors will be having long-term neurocognitive decline. So what is your take on avoiding PCRT if we give higher dose of methotrexate in these patients?
In T-ALL or T-cell lymphoma?
T lymphoblastic lymphoma, sir. TLL.
So we don't give high-dose methotrexate to our T-cell lymphoma patients. I know there are some groups that do, but it's hard for me to comment because we don't use it at all in T-cell lymphoma.
Okay. So we follow actually BFM protocols, sir. So
yes. Yeah, I recognize that some of their backbones, they use more high-dose methotrexate. The randomized studies in COG from the 90s show that there was no benefit to that, the high-dose versus Capizzi. So we've been using Capizzi for 20 years in COG for lymphomas. So again, it's hard for me to comment on if you're using the BFM backbone, like tweaking it, because again, I don't use it. So don't know as much about those nuances.
So if the patient develops press, okay, then with high-dose methotrexate, can we go with the rechallenging of high-dose methotrexate again?
We do. If you just have to wait till they fully recover from it. But yes, for patients so we give high-dose methotrexate a lot in B-ALL, for example, and we rechallenge them if they've had press.
Okay, so thank you, sir. What about, sir, the other question? What's your advice on vaccination for these survivors and post-allotransplant patients?
So our typical is we typically roughly 1 year after transplant, we start revaccinating with non-live vaccines, and over 2 years out from transplant, we start revaccinating with live vaccines. That's our big picture approach. We do more than we used to, some immune function tests and monitoring post-transplant. And if a patient had really poor immune recovery, because we're using a lot more RICs and other things, we might delay restarting vaccination until they have better T-cell numbers. Also, for patients who are continue to be on GVHD meds because they had GVHD, we don't restart vaccination until they're off graft versus host disease medications. I mean, eventually, if they, like for the patients with the rare children of chronic graft versus host disease that we can never wean off, we do restart vaccinating those patients sometimes, but that we have a detailed discussion of immunology as far as versus just having a standard approach, because it really depends on how much immune suppression, what vaccine you're talking about, that kind of stuff.
Okay. Thank you, sir.
In adolescent ALLs who are traditionally high risk, can we give them rituximab, and when latest should we start the rituximab?
So it's a great question. So this is newly diagnosed patients you're talking about?
Yeah, newly
Or-
diagnosed.
So, I mean, it's not something that we typically do in the US as part of our standard adding rituximab, but I know there are places that do it. And my bias would be if you're going to add it in, I would follow the protocols that studied it and used it instead of like choosing where you may want to give it. So like if you're following some of the data that came out of Europe, they gave like 20 doses, I believe starting it was a consolidation they started or second half induction. I would follow those protocols and pretty much do the same thing. I wouldn't like there could be a better way to do it, but we just don't have any data to suggest that.
And is there change on the length of maintenance between boys and girls?
So in the US, it's a good question. We are pretty much across the board, same length of therapy for boys and girls.
What about PEG asparaginase versus conventional in resource challenged countries where we cannot share the vials because we may have less number of patients? Efficacy versus, and what should we do?
So, I mean, well, two things. One, PEG asparaginase in the US is going away for cal asparagase. The company who makes PEG also makes cal, and they're making PEG go away soon. But I mean, I would say that I think the data comparing different formulations, they're all pretty comparable if you give equal amount of doses. So if PEG asparaginase, I know there's lots of places in the world that have a hard time getting PEG asparaginase. And in those places, native Norwinia, if that's what you have access to, work just as well. So I would use what you have access to, just knowing that if it's not PEG, you have to give more doses of conventional.
The last question is, if a patient presents with hepatic dysfunction at induction or develops hepatic impairment later during inductions, which drugs to avoid?
It's a good question too. I mean, in general, vincristine can have issues based on your hepatic metabolism, but that's really more if you have hyperbilirubinemia than having a transaminitis. Anthracyclines at really bad liver dysfunction can have issues. Steroids are fine. Asparaginase depends. I mean, for all those, it depends on the degree of hepatic dysfunction you have. Like for us, most of our protocols kind of give guidelines on if your bilirubin's over this times the upper limit of normal, cut the dose in half. If it's over this, hold it temporarily. And we kind of follow those. I don't want to say that there's like, I usually, it gets so complicated. I usually follow an algorithm, just knowing that vincristine, anthracyclines can have issues, and asparaginase can all have issues if your liver is really bad. But usually for patients who walk in the door in induction with liver dysfunction, it's transaminitis, not hyperbilirubinemia. And those patients actually usually do fine with most of our drugs. It's usually the patients who have like hepatopathy that have more issues.
Thank you, sir.
That's not usually the problem walking in the door.
Few questions lying in the chat box. You would like to take more questions? There's one about liver enzymes going 5 to 10 times above the upper limit of normal during the maintenance period with normal bilirubin. Will you withhold methotrexate and 6-MP?
So that also goes back to I usually follow our protocols, which and it just because that's how we got to be where we are today. For the most part, though, transaminitis in the 5 to 10 times range, usually we don't, with a normal Billy, we don't adjust that much.
Another question is, pH positive ALL on imatinib, do you omit PEG asparaginase?
No.
Is there a role of bortezomib during maintenance in T-cell ALL, T-cell lymphoma?
It's not been studied in that place. Most T-cell leukemia and lymphoma relapse early. So I actually don't think that adding it there would probably add that much benefit anyway. So since it's not been studied, and most relapses are early, I usually don't recommend giving it in maintenance without a trial to test it there.
One question is about the dose of PEG asparaginase, 2,500 versus 1,000.
So for PEG asparagase, we usually use 2,500. I use per meter squared. And then, I mean, I know that there are different formulations of the reason I don't want to say completely is different formulations of asparaginase around the globe. And there are ones that the dose is different. Like in Europe, they use a different formulation. So they don't use 2,500, they use a different dose. So, but if you're talking about the formulation that we use that's made by Servier in the US, it's 2,500 IU per meter squared. We used to not, but we've started to cap the dose now in very obese patients in the US based on, and the adults definitely cap the dose if you're over a certain age, because it seems to be a lot more toxicity of asparaginase if you're obese or if you're older.
Any data on ponatinib in pediatric pH positive?
I missed part of that. What was your question again?
Ponatinib for pH positive childhood ALL.
I mean, I think there's definitely some exciting data in the relapse setting using ponatinib. And there are data in adults coming out using blinatumomab and ponatinib as a combination. It doesn't seem that ponatinib inhibits the activity of the blinatumomab. There's always the risk. There was always the concern when you add a TKI because a lot of them inhibit T cells. Would that make the blinatumomab not work well? So I think it's, if you had a pH positive ALL that was relapsed or couldn't tolerate chemotherapy, I think blina plus a TKI is a good idea. As far as which TKI, I don't think there's very good data saying one is better than the other. And the options to follow a published backbone or ponatinib or imatinib or dasatinib are all been combined safely with blinatumomab and effectively.
Last question from the audience. To you. We have still vote of thanks from Acute. Is Acute there? They're not there, then on my behalf, on behalf of Mumbai Hematology Group, and Dr. is extremely grateful to you for doing this wonderful job. This was a very, very informative lecture and a great question and answer session. And also thank, yes, Yogesh, you're there. Go ahead.
Yeah. So thank you very much, sir. I want to thank all the faculties, Dr. M.B. Agarwal sir and Dr. David Teche, to take your time out and have this wonderful discussion about so thank you very much. And we are also commitment of ALL with our own HAMSIL, which is Pegasus, your support for HAMSIL, as well as we thank you for giving us opportunity to be a part of this scientific discussion. Thank you very much and good night, sir.
Thank you very much for having. It was a pleasure as always. Take care.
Thank you.